At 4 weeks, I would definitely move into some very gentle passive range of motion, right? We're entering that phase where we're protecting the shoulder, but what I'm trying to do is maintain what we have. Because again, the shoulder has this tendency to freeze up relatively easily. And if you're having a lot of pain, you're in a sling, you've been told by your orthopedic, be very careful with your arm, don't take it out of the sling unless you're doing X, Y, and Z. Some of our patients are really gung-ho and they will not move out of that sling for weeks. And what happens is that we get to the point where we can start moving them and there's just no motion to be had, right? That's scar tissue. So really that 4 to 6 week mark, my biggest concern is just making sure that we are maintaining the range to the shoulder. It's very easy on the patient. They don't do anything. We bring them in.
Passive range of motion.
Yes, us moving them, not them moving themselves.
And when do we start active range of motion?
Depending on the severity of the rotator cuff repair, usually somewhere between 6 and 8 weeks.
And then when would you expect maximum improvement, where you tell them you're going to be about as good as you're going to get with your shoulder surgery?
16 weeks. At about 16 weeks, again, depending on where the patient's trying to get to. If it is the dad who's taking care of his son and doing normal things in life, at about the 4-month mark, I would expect them to be using the shoulder pretty comfortably. If we're talking higher level athletics, overhead weightlifting and throwing in those things, I would say anywhere from 4 months to 6 months. So much of it is dependent on the degree of the tear that was repaired.
Right. I guess I'm more conservative. We actually, with a cuff repair, I tell them that they're high risk for recurrent tearing for 6 to 9 months, because that's based on data that bone healing of tendon to bone is 6 to 9 months. So I realize that there are doctors that have their athletes return earlier, but I'm on the conservative side, recommending that they don't assume normal activities, no matter how good they feel, until the 6 to 9 month period reaches. So.
I feel like, one of the both superpowers and hardships of physical therapy sometimes is that we're basing things on the individual, right? So much of what we see in front of us. I can tell you that any good physical therapist is playing it cautious. They're definitely not pushing that line. I tell my PTs, or, we're a teaching facility, if we have students, if your gut feels funny, just don't do it because it's not worth it, right? But again, like we talked about, sometimes we have athletes who are trying to get back on the field, trying to do these things, and they're not going to listen to me if I say, wait a year. Right. So we try to get them as strong as they can possibly be in the time that we have with them.
Right. I feel, having treated many professional players, including NFL players that I've treated, my observation has been that they're actually pushed into or return to sports earlier than I would do. I think many of the NFL treating doctors probably have a feeling that they're encouraged by their owners or CEOs, I'm not sure where the decision made, is to push the athlete quicker than they should into sports, and that's where we get in problems with the recurrent injury, which may end their career.
Yeah, I agree with that completely. Ironically, I think the group that I have the best follow through with are my collegiate athletes, because I feel like they tend to be the ones who are cautious enough. Maybe they have the wisdom enough to know they need to heal completely because they're trying to get to the next level, but they don't have the pressures put on them because they're not getting paid as if they're at the next level. In high school, like we talked about, oftentimes they're getting pushed by their parents. They're trying to get into college. They don't want to lose that time. But yeah, the college athletes tend for me to be the easiest to lead down that course to success. I've treated pros also, and I've run into the same thing where I'm like, listen, man, you just got to give it some time or you're going to hurt yourself.
Right. On the average, how many visits of physical therapy would you recommend before, let's say, you would tell them, go see an orthopedic doctor for x-ray and possible MRI? How many visits would be appropriate?
If I haven't seen significant improvement over the course of 8 visits, maybe 3 to 4 weeks, then certainly I'm starting to think, okay, maybe there's something else wrong here. Maybe the structure is more heavily damaged and it needs some surgical or steroid intervention, all those things that they can get from an orthopedic such as yourself. A lot of times I kind of think about you and I as a team, right? I feel like you're the guy who puts the tire on the car, and I'm the guy that makes sure that the tire rotates appropriately so it doesn't break now that it's reattached. And so if those structures are not attached anymore, or they are injured beyond just making everything move correctly, that's certainly when I'm starting to think, okay, you should go see the orthopedic, you should, get that MRI and see what the next step should be.
So let's talk about rehabilitation. Two of the surgeries we commonly do for shoulder pain. One is rotator cuff tear, where we do a repair, and secondarily with unstable shoulders, we do a labral repair, and they have a protocol for treatment. Usually when I make the referral, I just put down evaluate and treat. I always tell patients that when I first graduated, I would carefully write down instructions for the physical therapist. And then I learned that they're not really following my instructions. I think they're doing what they're comfortable in their rehab program. So I now firmly believe it would be best for the physical therapist to develop a plan. But I do have some cautions. I remember for a while it was really stressed after rotator cuff surgery to begin rehab right away. And my experience and observation was that sometimes if you started therapy early, actually you would see deterioration in function, and I would see a recurrent tear perhaps. So I developed a protocol of really waiting at least 6 to 8 weeks, allowing some rest and healing before we initiate a therapy program. So usually when I do a rotator cuff repair, I tell people, let's wait about 6 weeks and then start your physical therapy. That lowers the chance of recurrent tearing. And I think the current literature supports that you should probably wait. Similarly with labral repairs, again, recommendation is to stop, allow for some healing, and then maybe start rehab 6 to 8 weeks later. What is your opinion in this regard?
I think 6 weeks, makes a lot of sense. 6 weeks is that general tissue healing timeline. My concern is always this. I'm always concerned that if we wait too long, we're going to lose some of that range of motion, and then we're going to be fighting and fighting to make it up on the back end. I mean, that first 3 weeks, absolutely, very, very protective, right? Especially for something like a labral repair. You just need it to sit and heal. You need that structure to get really, really tight. But, when you start to get to that 3 to 6 week mark, if you have someone who's experienced, who knows what they're doing, I think there's value in having the patient come in, have the therapist range their arm, really just make sure that they're maintaining what they already have.
So your preference for rotator cuff or labral repair is to begin rehab at approximately 3 weeks?
I would say 4. I feel like when I get someone in at 4, there's enough of the tissues calming down, inflammation has come down so much that we can pretty safely move them without any issues, as long as you're smart about what you're doing. You talk about the protocol, right? You send it over and then it just kind of gets forgotten. And there are parts of the protocol, that first 6 weeks especially, where I feel like it's the same for everyone, or it should be, right? Protect the structures, maintain what mobility you can, but at the end of the day, you just want to make sure you're promoting healing and then you're not causing any injury. I think a lot of what you run into for the protocols and the variance between therapists is what comes after, because the patients are never like a textbook, right? The 55-year-old desk worker who has just a chronic tear in the rotator cuff is just not the same as the baseball player who tore the rotator cuff during the season and needs to not only get back to a very, very high level, but needs to do it quickly because they have to get back on the field. And so I think that leads to a lot of variance in how it's treated, especially when you hit those middle and end stages.
Right. So I found actually sometimes when an athlete is enthusiastic to return and you try to comply with them and make them happy, you then allow perhaps earlier or shorter rehab and return to sports. And then unfortunately, sometimes you're disappointed with the fact that they get a recurrent injury. What is your thoughts in that regard?
I would say, again, it's very athlete dependent because I feel like you have to kind of merge the two sides of, do you have an athlete who's going to do whatever they want to do, right? And if they're just going to go do it, are you doing them a disservice by not at least preparing them as well as you can? But certainly we are always educating all of our patients, listen, you need to give this time to heal. We cannot rush this. Like, a big part of recovery is just time, right? It's unfortunate. It's very frustrating for everyone, but you need to give it time or you're going to re-injure. But, I do think that you have to keep the patient's wishes involved or they're just not going to listen to you, especially from a rehab sense. So we move them towards their goals in the safest way possible while trying to make sure that they are not causing themselves any injury in their gusto to get back to playing.
How do you deal with parents who feel that their child is going to be a superstar, NFL star, and they're pushing for return to function, and also have problems sometimes with the player themselves covering up their disability, again, hoping that you give them clearance to return to sports? What are your recommendations in this regard?
I have a 2-year-old, and I think the thing that I appreciate the most out of our pediatrician is how blunt she is. And that's exactly what I try to do when it comes to my younger athletes whose parents are in the clinic. And I just try to be blunt and say, listen, I know you want them to get back. I know that she has soccer tryouts for college coming up. If you don't rehab this appropriately, they're going to get injured again, and then they won't be able to play at all. So you have to be willing to give this 2 months now to save yourself 2 years later. And I feel like that usually gets it across. Parents want their kids to be successful, but they also don't tend to want to risk long-term injury. And then the athletes themselves, it's twofold. One, educating them, just like I was talking about, of listen, you're going to get hurt again. Do you really want to have to do this over again and over again and over again because you can't slow down a little? But also watching them. It's pretty clear when they can't actually do what they want to do. We'll say, okay, this has been looking great, let's progress it. But we know what it should look like if you can tolerate it, if you can do it well. And if we see that you can't do it well, we're going to tell you right away, listen, you're just not ready for this. Let's pull back, let's give it a week, let's get stronger, we'll try again next week and we'll work our way into it. And that usually leads to very good results.
So you outlined probably in somebody with garden variety shoulder pain, maybe injury painting at work or at home, overhead where they develop shoulder pain, that maybe initial assessment would be approximately 8 physical therapy visits. How many visits do you think is reasonable for, let's say, rotator cuff or labral repair? Now, I know in workers' compensation cases, at least in California, they usually will approve 24 up to 36 visits. Is that appropriate? What are your thoughts?
I think it depends on where our end goal is. For our higher level athletes, absolutely. The more we can do, the better to really harden that shoulder and make sure that it's moving appropriately, it's strong. They're not going to re-injure. In general, I would like to be able to see them at least through the 12-week mark. I really like to get to that 12 weeks. In an optimal world, 16 weeks. At 16 weeks, if we don't have you back to doing everything that you want to be doing reasonably, something is probably not where we want you to be. And oftentimes that necessitates a conversation with you of, hey, this range of motion is lacking, the strength is lacking, we're still having pain and we don't know why.
So how many visits are ideal then, let's say post-rehab for rotator cuff or labral repair?
Well, if I'm seeing you, let's say at week 4, and I'd like to see you, ideal, in an ideal situation, I would say around that 24. I think around 24 visits, scattered over time.
There's a different animal that maybe we should talk about, which where the patient really presents with severe pain, disability, and they have adhesive capsulitis. They have severe loss of range of motion. They can barely lift their arm forward, backward, significant loss of internal and external rotation. How do you rehab those individuals?
Depends on the phase, right? There's the 3 phases of adhesive capsulitis, frozen shoulder, freezing, frozen, and thawing, right? Ideally, we see them when we are just at the tail end of that frozen phase, and we start to enter that thawing phase where the shoulder starts to allow itself to move. So, for whoever's watching this, you get frozen shoulder when the capsule essentially that wraps around the head of your arm bone, your humerus, starts to adhere to itself basically, and you no longer have any motion to get around in here. And it's what we call a self-limiting disease, right? Somewhere between 12 and 18 months in, we would expect that you would have regained 90–95% of your range as your body pairs off all of that scar tissue and whatever it is that it laid down. What physical therapy is trying to do is speed up how much that joint mobility is coming back. So we're trying to increase the mobility of the joint itself by doing glides and things, and then obviously stretching you in a way that you just cannot do to yourself, be it because of pain or whatever is restricting you, and then dealing with all the other compensatory issues that come from that. Because if you're like this for a long time, even if the joint starts working, that chest muscle has tightened up to the point you can't pull it back. These muscles have stretched out and are now weak, and now you can no longer move appropriately. So even if we just magically gave you the range back, you wouldn't be able to use it because you would just end up with all these other injuries. So, the big thing, speeding up that increase in mobility and then dealing with all the other compensatory stuff so that when you are back to normal, you don't have a bunch of problems because of it.
So one of the things that I do, and maybe I should, your thoughts on it, and frozen shoulder, what I believe in and has worked for me is to do, when they're not responding to physical therapy, is to do a corticosteroid injection. And I've often resorted to manipulation under anesthesia to break up some of the scar tissue. And then we usually plan to do immediate physical therapy right after. I think if you do a manipulation and you don't do physical therapy, you lose all the motion did that. So just for individuals not familiar, we actually put the patient asleep. Then I really stretch the shoulder out in all planes. It's amazing how much motion we can gain, and then start them immediately. We advise them almost the next day to go to physical therapy so that they can maintain the motion. My experience has been we get fairly significant improvement after the cortisone injection and manipulation under anesthesia. What are your thoughts?
Yeah, I think you're absolutely right. In the importance of the speed of starting the rehab after that MUA. Normally what we tell our patients if we have some time in advance of the plan is we want to see you every day. I want to see you every day for the next 5 days or whatever we can see. Because what tends to happen, if we don't see them right away, it immediately starts to adhese again, right? So by our getting to see them for the consistent days as that healing process goes through, it never allows it to get stuck again. Same with the steroid. I've seen a lot of patients who have significantly benefited from the steroid, but with the MUA, I would say, at least from us, the most important thing is just to get them in quickly and consecutively. Like, it can't just be the next day and then we'll see you in a week. It has to be like procedure on Monday and then Tuesday, Wednesday, Thursday, Friday, we get you in and we are ranging that shoulder. And we're aggressively ranging that shoulder because we don't want to lose what you have just added for us.